Thank you, John, for the invitation. Great to be debating here. Steve, I think that he's right. We're not going to have a lot of difference of opinion on allogeneic transplant. So, a quick story first. Be interested in Sydney Webb, where members of the British aristocracy, founders of the Fabian Society and the London School of Economics in the 1900s, socialist, social reformers, and historians. They published a very influential book in 1935 called Soviet Communism, A New Civilization, ? After going back a few years later, they updated the book, Soviet Communism, A New Civilization without the question mark, so it's an affirmative. So I wanted to give anything away, but I'm going to talk about, allogeneic bone marrow transplant. I'm adding the question mark instead of taking it away. So some of the questions that we want to address are how to frame the picture, T-cell lymphoma compared to other heme malignancies. What is the evidence for graft versus lymphoma effect? Autologous versus allogeneic. Allogeneic as a front line, perhaps autologous in a small subset of patients with relapsed disease. And what comes after that. I'm going to have just the time to very briefly touch on each one of these points. So when we talked about stem cell transplant, allogeneic in T-cell lymphoma, what kind of model do we have in mind we can follow? Now, chronic myeloid leukemia, clearly it's a disease where the role of transplantation has been completely changed due to the development of a very effective therapy. But there's a single driver mutation targetable, predictable clinical course with a chronic phase initial and then blast transformation, and also a very specific tumor burden methodology guiding intervention. So obviously peripheral T-cell lymphoma does not fit this particular model. Another model would be the CLL, where allogeneic transplantation has never had really kind of a very significant impact, certainly not as much as chronic CML. Nonetheless, CLL does not have a single driver mutation, although there is a dominant signaling pathway activated, which is targetable. It does have a predictable clinical course, and there's also a way of measuring minimal disease that is fairly accurate. I don't think that peripheral T-cell lymphoma followed that pathway either. So I think that probably peripheral T-cell lymphoma is similar to acute myeloid leukemia, perhaps ALL, in that it is very genetically heterogeneous, and it tends to affect more than one lineage. And I think that's the challenge that we have with, in fact, I think that there are a lot of parallels between AML and peripheral T-cell lymphoma. So one of the issues is that a lot of the peripheral T-cell lymphomas are rare, as my distinguished co-panelists here published very recently. Zebras and hen teeth make a big part of the scenario here. The issue is that the zebras are more common than you think, and in fact, even in the peripheral T-cell lymphoma, not otherwise specified, which is right here, if I can get it. So I think that, as Steve has shown, the molecular heterogeneity is so great that I think that you can consider even that category as a cluster of zebras, essentially. Now, that, of course, is the International Peripheral T-cell Lymphoma Project, which is an international registry. It's an international collaboration. Here are the U.S. cases where you see that even in the U.S., up to 30% of the cases of peripheral T-cell lymphoma really are very rare subtypes. Okay, so how to think about allogeneic stem cell. Zebra and hen's teeth usually bad and make a large fraction of the cases, so we have to deal with those on a case-by-case basis. I think that there is a certain holy grail narrative in the approach to allogeneic transplantation that needs to be recognized and perhaps criticized and faced with evidence. Of course, in the peripheral T-cell lymphoma, there are not many changes of getting second and third remissions after primary failure. And the question is, as Steve was saying, the novel agent versus allogeneic bone marrow transplant is really not a real dichotomy because you have to have some control of the disease anyway before taking the patient to allogeneic transplant. So I don't think really kind of is a simple dichotomy. The role of allogeneic, of course, is based on the fact that we do see graft versus lymphoma effect, and then the question is when. Some institutions are looking at perhaps transplanting patients in first remission with particularly high-risk type of peripheral T-cell lymphomas. Would that be, what about second remission, perhaps in angioimmunoblastic peripheral T-cell lymphoma, NOS, and EATL? Third remission later for cutaneous T-cell lymphoma, or never. I think that it's wide open as to the strategy. So there's quite a bit of data on graft versus lymphoma effect that I don't have the time to review here. I just want to point out a recent study from the French transplant group because it's nice and shows kind of a nice algorithm in terms of how they treated the patient. This, of course, is retrospective, and 373 patients received allogeneic stem cell transplant. They went to that database. They identified 76 patients that had relapse with a median time to relapse of 2.8 months, and that's a breakdown of the histology in that group. The treatment at relapse really was selected by the local physician, so this was an prospective selection of therapy. Some people received chemoradiation, some people received DLI, and 63 patients were eligible for analysis. Right there to your left is just the overall survival curve, which looks pretty good considering the patient population, although these, of course, are highly selected cases. And to the right, you have the graphic demonstration of how patients were selected for therapy. And I can't see it from here, but on the left of that graph, there is a small number of patients that received DLI, either in combination with other therapies or by itself. They describe here that some responses, including complete responses, were observed in patients who received DLI, even when it was given by itself. And some of these responses were durable. We're talking about 20 to 22 months. Responses. I think that everyone who does allogeneic transplant in peripheral T-cell lymphoma has seen those kind of responses to DLI immunomodulation. The question is what kind of patients those are, and I want to point out here that a significant fraction of patients here had cutaneous T-cell lymphoma, which is notoriously sensitive to immunomodulation, even after allogeneic transplant. So outcome data. Steve mentioned the registry data, which were published in 2013 by Sony Smith. I think that I have 3 slides on the data. They're kind of busy. We may not go through all the different numbers. The bottom line is that with the exception of non-transplant mortality, non-relapse mortality, there's no significant difference in outcomes between all these populations. So the registry looked at patients who received auto transplant or allogeneic transplant with myeloablative or reduced intensity conditioning, and the numbers are shown there. Fairly large population, 241 patients. The non-relapse mortality for the whole population, myeloablative and reduced intensity conditioning, is fairly high, and I think that this is consistent with what a lot of other studies have shown. The percentage of relapse and progression are high across the board, and the progression-free survival and the overall survival are not very different. This is for the subset of patients who were transplanted beyond CR1. It's 171 patients. And as you can see, there is no significant difference either in this population. There is a subset analysis by peripheral T-cell lymphoma subtype. This is just helpful and interesting from the standpoint of looking at the numbers and the distribution of the subsets. But again, there is no significant difference in the outcomes in this population, with the exception of non-relapse mortality. So these are the survival curves for the subsets, and the conclusion of the study was that essentially in this population, the autologous and allogeneic transplant, for a variety of reasons, were not significantly different in terms of the outcomes, except for the non-relapse mortality. Now, there are some problems with this study, of course. More than 50% of the patients on the autologous group had anaplastic large cell lymphoma, and the ALK status for these anaplastic large cell lymphoma was actually not reviewed because there was no central review of pathology. On average, the autologous patients were transplanted earlier than the allogeneic patients, and of course, there was selection bias in terms of which patient was sent to auto as opposed to allo. For the allogeneic patients, almost all patients were transplanted past CR1. They had a greater number of therapies and regimens. 60% of the patients had myeloablative conditioning, which would be kind of the opposite of what we would be seeing now, where about 2/3 of the patient or more would be getting reduced intensity conditioning. So intent to treat. Now, there is a kind of a interesting study. Of course, this is intent to treat a retrospective. But nonetheless, I thought I would show it. This is from a single center in France for feeding data to the EBMT. The study population is untreated advanced patients with peripheral T-cell lymphoma, aged less than 70. The ALK positive and Tcell were excluded. The breakdown of histologies is shown there for 49 patients. The median age was 50, so this was a fairly older population. 19 patients were older than 55. All patients received CHOP, which is not very effective as a frontline therapy in peripheral T-cell lymphoma, and more than 60% of the patients had reduced intensity conditioning. These are the curves, which are not particularly sort of interesting, except for showing that winners win and losers lose, as we already know. Of course, the patients who were selected for allotransplant had a donor and were able to get it. They tend to do very well. They may do, the survival, the flat line here is very high. Of course, this is highly selected. But we know that for a very selected group of patients, allogeneic transplant is very effective and curative. The patients who were not eligible, of course, didn't do that well. This is just a breakdown to point out that 40% of the patients that were initially intended to receive allogeneic transplant, they did not get it, of course, and this is expected. 13 patients dropped out, mostly because of disease progression, and 7 patients did not have a donor. And those are the progression-free survival and overall survival percentages there. The transplant-related mortality in this study was 8.2%, but again, this is a single center, highly selected patients transplanted immediately at front line. So, okay, what to do with the zebras? I only want to point out that in selected cases with patients with highly aggressive T-cell lymphomas, allogeneic stem cell transplant definitely should be considered based on the response quality and the age and the performance status. This is a study from the EBMT showing, I think, 18 patients with hepatosplenic T-cell lymphoma, which is a very chemo-resistant, difficult lymphoma to treat, showing a good outcomes with allogeneic transplant. So conclusions. A majority of the patients with refractory relapsed peripheral T-cell lymphoma are not really eligible for allogeneic transplant due to age, comorbidities, and all the reasons that we already have discussed. For eligible patients, allogeneic stem cell transplant remains a high-risk procedure in light of the transplant mortality, which in most studies is between 25 and 30%. That doesn't mean that you shouldn't do it, but you have to consider the consequences. For subset of patients with refractory relapsed peripheral T-cell lymphoma, autologous stem cell transplant is an option, may be considered before allogeneic stem cell transplant. And these cases include anaplastic large cell lymphoma, perhaps angioimmunoblastic T-cell lymphoma, again, depending on selected cases. For a subset of high-risk neoplasm, allogeneic stem cell transplant may be considered in CR1. Again, here comes the judgment. I think that a lot of us would transplant T-cell PLL in CR1 in the small fraction of patients that has the right age and the good performance status is in complete remission. All the lymphomas that derive from innate immunity T cells, like the gamma delta T cells, some NK, perhaps a type 2 enteropathy associated, they are extremely chemo-resistant. Those patients, if you can get them into a complete remission, I think that a lot of us would seriously consider the possibility of doing an allogeneic transplant if the right age is there and the donor is available. And I don't have a lot of experience and I didn't have the time to talk about it, but I know that our Asian colleagues treating ATLL, HTLV1 related, they certainly see very good results with allogeneic transplant. The data that are available definitely support a graft versus lymphoma effect, particularly in CTCL and angioimmunoblastic, and the treatment must be individualized. For every other question or concern, you get the book that Steve and I are adding. Thank you so much.